So can we go again over what the CAVE is for,
Absolutely.
and
So,
what part of the foot, like forefoot or hind foot, that we're referring to when we
sure.
talk about it?
So, the four deformities are present on that day one. Your day one cast should assess, is there cavus? Not all of them have cavus, but is there cavus? And uh, does that cavus need to be corrected before you start pushing on the foot? Because what that does is that is the forefoot that is completely off from the midfoot, which is then completely off from the hindfoot. And by restoring the position of the forefoot, by getting rid of the cavus, you've now got the forefoot and midfoot hooked back up together. So when you then put an eversion force on the first metatarsal, that pushes the entire now connected midfoot through the cuboid, which engages the calcaneus. And so that is the calcaneopedal block. So as you push on that forefoot, you are rotating the entire midfoot and hindfoot together. All those deformities correct together. And Ponseti said you have to get at least 50 degrees of external rotation of the foot relative to the position of the knee in eversion before you talk about dorsiflexion. And he would talk about you could feel the anterior process of the calcaneus just below where your thumb is on the lateral talar head. And when you can feel that anterior process, you know you're ready to do the fourth deformity, which is the equinus. You may not address the equinus until you've corrected the other deformities. It's a huge mistake. There's a very, very specific exception to that rule, and that's for something called an atypical complex clubfoot, which has a very good paper written by Morquende, and I think Ponseti was still alive when he wrote that paper.
So it seemed like the key, this is just kind of summing it up, and I know it's more complicated than this, but sounds like the key is getting the eversion through the first metatarsal initially. You need at least 50 degrees of external rotation, but by doing this, trying to get this plantar flex first metatarsal back everted, that is actually correcting the forefoot. Sound like we said forefoot, midfoot, and to some extent the hind foot as well.
Correct. So so when you push on the first ray externally, it pushes on the calcaneocuboid joint, which then everts the calcaneus, dorsiflexes the calcaneus, and rotates the calcaneus out of varus into valgus. There's an analogy in one of those global health videos that I really, really liked, where he said the calcaneus is like a ship cresting a wave. When a ship crests a wave, it has to pitch, yaw, and roll simultaneously to stay afloat. So does the calcaneus when it moves. You can't just try to move it in one direction. It happens in all three planes at the same time. So as you push on that foot externally, you're moving the calcaneus in three planes underneath the talus and through the subtalar joint.
Okay. I like that. And also I kind of heard you saying it just sounded like an excellent pimp question, probably a little bit more so towards fellow level, but you can't, you can't even consider, really fixing the equinus until you get about at least 50 degrees of external rotation before trying to work on dorsiflexion.
That's a test question too. So what happens if you do that is if you cut the Achilles and you forcibly push on the foot to try to get him out of equinus, the calcaneus isn't going to move because it's still stuck underneath the talus. And so where you're going to dorsiflex is through the midfoot. And that's where you get an overcorrected, horrible flat foot with clubfoot. It's bad news. I mean, I love treating clubfoot because you can take somebody that would otherwise have a lifelong debilitating problem, and before they're even in preschool, they're completely done with their treatment and look awesome. I mean, a handful of them go on to need some small surgery along the way, but nothing major. The major goal of the Ponseti treatment is, and I skipped this and I shouldn't have skipped this, is a painless, flexible plantigrade foot. It's not a foot designed to win a beauty contest. It's going to look a little bit different than a normal foot. The most obvious way a foot looks different, if you look at your own foot and you look at your extensor digitorum brevis, and it has that nice convexity to it. Every clubfoot has a very underdeveloped extensor digitorum brevis, along with every other muscle in their leg, and it looks a little different. And even if you have a perfectly symmetric and length foot, and there's no real shoe size difference, you can always tell which one is a club foot by looking at the EDB. So the goal of Ponseti is to stay out of the joints. And that's why his treatment is so important, because once you operate on a club foot and you go through a joint, that joint is never the same again.
So we can move, and we pretty much did just talk about the Ponseti method for the most part, but
Yeah.
what about if you do nothing at all? Say
Well,
this.
actually, but before I get to that, there's a couple things I didn't talk about which have to be talked about. I'm bad for not mentioning it. It's a long leg cast. It's always, always, always a long leg cast. You cannot control the rotation through a short leg cast. There still are some jokers out there trying to do it that way, and you can't do it. And I know because I see their patients long term, and you can't correct it that way. So that's first and foremost most important. Now, if you don't correct this, I don't know if you guys have ever traveled internationally, but you will see people out there who have uncorrected club feet, but they're not young people, because through Ponseti's international organization, almost every country in the world has people treating club feet now. But when I traveled to the Dominican Republic in the early 2000s, I used to pass a guy every day who would panhandle and had a unilateral club foot. And I got up the courage one day to go talk to him and say, hey man, I'm working at a charity hospital. We can fix your foot. He said, I was never educated. My family gave up on me. This is the only way I can make money, is by panhandling. And so, that guy was literally walking on the dorsum of his foot, right? Because that's how it's shaped like a club. Look at that. The people listening can't see it, but on the screen, if you're watching on YouTube, you can see the infant model. That first picture, you'd be walking on the lateral border of your calcaneus and your talus. And so your body, what's really weird is you develop a calcaneal fat pad there.
Yeah.
And
so
you can't wear shoes. It's a lifelong problem.
Yeah, I mean, of course, that will be a big issue, right? I mean, you'll probably have where your skin calluses there in that area, like you say, the problems with shoe wear. I would imagine. I don't know. Is there any increase in like infections or anything like that? I guess skin breakdown.
Not that I know of. It is possible to fix way later in life with like a triple arthrodesis, but I will tell you that so a few PD pods who like to travel overseas. Dave Spiegel from CHOP is one of the ones who's published the most on beginning the Ponseti treatment in the walking age child, and he has really amazing results treating kids between ages 1 through 6. And I think something like only like 14 or 15% of those kids needed operative treatment. So even in an older kid, you can start Ponseti treatment. I mean, it just works. And that's actually how, when you get a relapse, your first treatment isn't the knife. Your first treatment is casting again, trying to restore some of that treatment back by casting it out.